So I'm going to present a difficult case to me with actually open ending. The story doesn't end yet. So I'm going to ask you a lot of questions. In fact, some of the questions have been answered by 2 lectures I've attended this morning and this afternoon. So let's start. And this is a 45 years old lady from the Philippines. She presented in 2014, in March at the time. And she had a history of TB lymphadenitis in 2010. And then she presented with a number of opportunistic infections, including a MAC in the blood, and also rhodococcal infections with a positive culture from bone marrow and also from the lung. And she also had suspected histoplasmosis from the biopsy taken transbronchially as well. And she has been treated with a number of antimicrobials, including amikacin, azithromycin, ethambutol, rifabutin, vancomycin, carbapenems, and also itraconazole. So she was tested positive with CLF2AG subtype, and the baseline C was really bad, just 1. And the viral load baseline was really high also, 1.8 million copies per mil. And in 2014, in our clinic, baseline GLT was still not yet a routine service. So there was no baseline GLT available. And she has been started with antiretroviral therapy with tenofovir, and emtricitabine with Truvada, and also the standard dosing of raltegravir. So about a month after starting treatment, the viral load dropped from the 6 log to 3 log. The CD4 improved a bit from 1 to 19. And because during her hospitalization, there's some renal impairment, therefore the rifabutin was adjusted to a lower dose. And later on, we used TDM and stepped up the dose to 300 milligram daily. And actually, the itraconazole was stopped later because the histopathological review actually did not show conclusive evidence of histoplasmosis. So about after 4 months starting antiviral treatment, the viral load rebounded from 3 log to 4 log without ever actually being suppressed. And the CD4 went back down to 6. And so a GRT was done at that time, including integrase. There was only the L10 and also, I think, K20 at the beginning with some only minor PI mutations. And non-adherence was thought to be the most probable reason for the virological failure, and therefore has been recruited to intensify drug adherence program, closely monitored by our case managers. And rifabutin was discontinued at that time to use just 2 drugs for the MAC, and also with pill burdens also in mind. And however, despite all these, about 7 months after starting the treatment, the viral load actually further rose up to 5 log, and the CD4 remained at less than 10. And therefore, without resorting to a GLT results at that moment, we switched the patients empirically from the original regime of Truvada with raltegravir to tenofovir, cidovudine, and boosted darunavir, believing that actually M184 or integrase resistance might have happened already. In actually the same time, the GLT results came back later, showing N155H and also secondary mutation of V151IV present at that time. Despite switching the therapy, about 2 months later, the patient's viral load dropped to 3 log, but rapidly rebounded 4 or 5 log with still very low CD4. And however, at this point in time, we repeated a GRT, including integrase again, which only showed minor mutations, and in which the integrase resistance has disappeared, probably without the selective drug pressure at that moment. We stepped up the boosted darunavir to BD dosing despite not having major PI resistance. And also the patient actually reported quite good drug adherence after joining the program, and also the occupational therapy, and she actually had been returning to the clinic every week to refill her pill box and receive further intensive counseling. And she actually had another round of multiple infections because of the immunological failure. And that was up about 6 months after the ART switch. And in which the C4 was only 85 at that time. And she was confirmed by the CSF studies to have VZV encephalitis and vasculopathy, and also cryptococcal meningitis. So she had been treated by azygovir, amphotericin B, and fluconazole sequentially. And and then for the months later, she remained not fully suppressed, although the viral actually gradually go down to about more than 1,000. For example, in the 2015, June and to December, the viral remained at 4 log, with the CD4 rising a little bit to 110 to 160. A repeat GRT showed only the same minor PI mutations. At that time, we added on VTC because we thought that at least the M184V was not there. And then by combining using Combivir, we are not adding further pill burden to these patients. And she did have a little bit of less than 1 log drop of the viral load further after intensification, and with a little bit improvement in CD4s as well. But then the GLT still show the same minor mutations, despite reporting full drug adherence. And the latest progress is that the patients actually, the viral load dropping to 3 log, about 1,000 to 2,000. And the CD4 actually somehow improved to more than 200, and actually at one time more than 300. And since 2 years ago, in April 2015, when she presented back with cryptococcal meningitis and VZV encephalitis, she actually had no opportunistic infections. Actually, she had no admissions related to infections at all for the past 2 years. So to summarize, this is a case with advanced AIDS with multiple OIs, and she had a heavy pill burden with some potential drug-drug interactions, for example, like rifabutin, itraconazole, and also raltegravir, and probably the suboptimal drug adherence. She had treatment failure with acquired integrase resistant mutations and had incomplete immunological and also partial virological response. So this is actually my last slide. So just to summarize about the trend of the CD4 and also the viral load. As you can see, this viral load after initial treatment did go down to about 3 log, but then quickly rebounded, probably because of drug adherence problem. And then we changed drugs to second-line drugs, and then viral load somehow beginning to go down. But now we have repeated the GLT for a number of times already, still showing only minor PI mutations. I would like to use this case as a platform for, as a discussion for further use of integrase inhibitors in these patients. So this is really the last slide. So I'm just brainstorming on what we can do right now. And because pill burdens is a potential issue in this patient because of non-adherence, shall we use just one pill, for example, like Atripla or Complera, because the patient actually has not been exposed to NNRTI at all, although the low genetic barrier could be a problem. Should we use just one pill with Triumeg, but then the patient had previous resistant mutations to raltegravir with 155 already. And then shall we use some not so maybe smart choice, like using Strivil with alpha-ticagrelor, but then plus darunavir, because we can use the cobicistat in the Strivil as a booster for darunavir, while using only 2 pills. And then the fourth choice might be to use Chalmet plus booster darunavir, but then the pill burden will be increased. Or can we use like only QD or BD dosing of dolutegravir with boosted darunavir, or we shall use just like the case mentioned this morning with the HIV-HCV co-infection with persistent virological failure. Should we just hold on, use the same regime? At the end of the day, the patient still has quite okay CD4 at this moment without any clinical events for the past 2 years. So, or we should ask ourselves to do better in terms of drug adherence counseling, to just stop all ARV to prevent other drug resistance occurring.